very good morning to all my dear students. I am Dr. Durgadevi, Assistant Professor from the Department of Oral Medicine, Vinayaka Mission Sankaracharya Dental College. Today's topic for discussion is corticosteroids in oral diseases. Corticosteroids are the substances that are naturally produced in our body. They are the group of hormones with similar chemical formulas which are secreted by the adrenal cortex. The adrenal gland is the source of a diverse group of hormones which are essential for the metabolic control, regulation of water and electrolyte balance, and also regulation of the body's response to stress. The two major types of adrenocortical hormones are the mineralocorticoids and the glucocorticoids. The corticosteroids and their synthetic analogues are commonly used for their potent anti-inflammatory and immunosuppressive property in the management of diverse conditions which are associated with chronic inflammation and immune phenomenon. Wide applications of corticosteroids in dentistry can be mainly owed to their excellent anti-inflammatory and immunomodulatory properties. Moving to the physiology of these corticosteroids, the adrenocortical hormones are classified according to their biological effects. They are classified into glucocorticoids and mineralocorticoids. The function of the glucocorticoids is to exhibit important effects that increase the blood glucose concentration and have additional effects on both the protein and fat metabolism. And mineralocorticoids, they affect the electrolytes of the extracellular fluids, mainly the sodium and potassium in particular. The aldosterone is the principal mineralocorticoid and cortisol is considered as the principal glucocorticoid. This is the HPA axis which shows the secretion of the cortisol hormones. Every day, the adrenal gland normally produces about 24 to 30 mg of cortisol but may produce up to 300 mg of cortisol in times of great stress. This is the classification of glucocorticoids based on the duration of action. So depending on the duration of action, the glucocorticoids are classified into short acting, intermediate acting and long acting. Short acting, the T half is less than 12 hours, for example hydrocortisone and cortisone. And intermediate acting, the T half is between 12 to 36 hours and the drugs are prednisolone, methylprednisolone and triamcinolone. And long acting, the T half is greater than 36 hours and the drugs include paramethasone, dexamethasone and betamethasone. And coming to the mineralocorticoids, they are classified into desoxycorticosterone acetate, fludrocortisone and aldosterone. This is the classification of topical steroids, and the topical steroids are classified based on their potency as low potent, medium high potent and super high potent drugs. Under low potency, we have fluocinolone acetonide in the percentage of 0.01, hydrocortisone available in the percentages of 0.25, 0.51 and 2.5. Under medium potency drugs, we have betamethasone, dexamethasone in the percentage of 0.1 percentage, fluocinolone, triamcinolone in 0.025 percentages. And medium high drugs, we have betamethasone, dexamethasone and triamcinolone in 0.1 percentage. High potent drugs, we have triamcinolone in 0.5 percentage. These are the therapeutic indications of corticosteroids. Corticosteroids are widely used in case of musculoskeletal and connective tissue diseases, for example rheumatoid arthritis, systemic lupus erythematosus and vasculitis. In case of respiratory diseases like sarcoidosis and chronic bronchitis, gastrointestinal diseases like ulcerative colitis and Crohn's disease, allergic disorders like asthma, hay fever and allergic rhinitis, skin conditions like pemphigus, eczema and dermatitis, and eye diseases like conjunctivitis, uveitis and optic neuritis, and in various oral and maxillofacial diseases. The applications in the management of oral lesions and conditions, corticosteroids are widely used in recurrent aphthous stomatitis, oral lichen planus, oral submucous fibrosis, Behçet's disease, erythema multiforme, pemphigus, mucous membrane pemphigoid, bullous pemphigoid, systemic lupus erythematosus, Bell's palsy, post-herpetic neuralgia, Ramsay-Hunt syndrome, TMJ disorders, temporal arteritis and cheilitis. These are the mode of administration of corticosteroids in oral diseases. It can be applied topically in the form of cream, ointment, gel, mouth rinses and liquid vehicles. It can be given systemically and it can also be given intralesionally. So now we'll see about the application of corticosteroids in individual oral diseases. First comes the recurrent aphthous stomatitis. Corticosteroids basically have no effect on the primary disease mechanism, but they are able to interfere with the inflammatory reactions as well as the T and B lymphocyte functions. Corticosteroids limits the inflammatory processes associated with the formation of the aphtha. It may act directly on T lymphocytes and alter the response of effector cells to the precipitants of immunopathogenesis. Moving on to the Behçet's disease, the mainstay of treatment for Behçet's disease is the immunosuppressive therapy. The successful treatment includes anti-inflammatory agents that modify the activity of neutrophils in case of Behçet's disease. In the acute phase, prednisolone at the doses of 40 to 60 mg per day may be beneficial. It may be used alone or in combination with other immunosuppressive agents. The next comes the oral submucous fibrosis. Corticosteroids prevent or suppress the inflammatory reactions, thereby preventing the fibrosis of the oral mucosa by decreasing the fibroblastic proliferation and deposition of collagen. So, intralesional injections of corticosteroids are very useful in oral submucous fibrosis. They can be used alone or in combination with other drugs. Dexamethasone can be given intralesionally in the dosage of 4 mg per ml in combination with 2 parts of hyaluronidase and 1 ml of 2% lignocaine. And triamcinolone can also be administered intralesionally in the dosage of 10 mg per ml with 1 ml of 2% lignocaine. Moving on to oral lichen planus, the benefit of steroids to some extent can be explained by the anti-immunological properties with the suppressed T cell functions and decreased IgG synthesis in case of oral lichen planus. Steroids have no effect on hyperkeratotic lesions, while the atrophic and erosive types respond to the local or systemic corticosteroid application. In case of oral lichen planus, various types of steroids are used either systemically or topically. So, under topical steroids, we have clobetasol propionate. They are used in the dosage of 0.05% 3 times per day. And betamethasone valerate, it is also used topically in the dosage of 0.1 to 0.05% 3 to 5 times per day. Fluosinonide, it is also used topically in the percentage of 0.05 6 times per day depending on the severity of the lesions, and clobetasol butyrate used topically 0.05% 3 to 5 times per day, again depending on the severity of the lesions. And triamcinolone is a drug which is used topically and intralesionally. Dexamethasone is used topically in the dosage of 0.1 mg per ml, and prednisolone is used systemically in the dosage of 10 to 20 mg per day for moderate to severe cases. Next comes the pemphigus. Steroids interferes with the lymphocyte subpopulations and supposedly lower the autoantibody protection in case of pemphigus. An immediate reduction of vascular permeability may prevent the leakage of these autoantibodies, complement and inflammatory cells to the focus and stabilization of epithelial cell membranes. So, these are the drugs which are used in pemphigus. Corticosteroids can be used topically, systemically and intralesionally. In case of topical treatment, we can either use it in the form of paste or an ointment, or the mouthwash can be administered as a monotherapy, or it can be used as an adjunct therapy with other immunomodulatory agents. So, moderate to high potency topical steroids should be applied twice or thrice a day in the percentage of 0.05 depending on the severity of the lesions. And systemic drugs, we can use prednisolone in the dosage of 1 mg per kg per day in 2 or 3 divided doses for 6 to 10 weeks and followed by the tapering of doses. And intralesionally, triamcinolone acetonide can be administered in the dosage of 1 gram per day over 1 to 3 hours for a few consecutive days. Next comes the benign mucous membrane pemphigoid and bullous pemphigoid. The benefit of steroids in bullous pemphigoid and benign mucous membrane pemphigoid might be due to its anti-inflammatory actions, lowers the enzyme release, reduced cell migration, decreased leakage of humoral factors. Patient with localized lesions, we can use high potency topical steroids, and patients with severe disease, we can go for systemic steroids, or the systemic steroids can be combined with other immunosuppressive drugs. So, in case of mucous membrane pemphigoid, fluosinonide and clobetasol can be used in the percentage of 0.05, or it can also be used in an adhesive vehicle type. And in case of bullous pemphigoid, again clobetasol is used 10 to 30 gram daily. In case of systemic treatment, prednisolone is usually given at a dose of 1 to 1.5 mg per kg per day, and depending on the severity of the lesions, we can either reduce or increase the dosage of prednisolone. Next comes erythema multiforme. This is a blistering ulcerative mucocutaneous condition of uncertain etiopathogenesis. The most common etiologic association with the erythema multiforme is the HSV, also called as a herpes simplex virus infection. In mild cases, ulcerations develop affecting the oral mucosa. In severe cases, there is diffuse swelling and ulceration of the entire skin and mucosal surfaces. So these are the interventions for erythema multiforme. Topically, clobetasol propionate mouthwashes can be used, and systemically prednisolone can be used in the dosage of 40 to 80 mg per day for 1 to 2 weeks. Then the dose is tapered frequently. The next disease is the lupus erythematosus. This is a classical example of an immunologically mediated condition and is the most common of the so-called collagen vascular or the connective tissue diseases. So in case of lupus erythematosus, the oral manifestations are very common, and in case the patient presents with the oral manifestations, we can administer topical betamethasone or clobetasol twice or thrice a day depending on the severity of the lesions, and systemically prednisolone can be administered in the dosage of 10 to 20 mg per day or a dosage of 40 mg per day in case of severe lesions. These are the other conditions in which the corticosteroids are used in dentistry. We can use it in Bell's palsy. The treatment is mostly conservative in case of Bell's palsy, but if there are no specific contraindications, immunocompetent patients are administered prednisolone in a dosage of 1 mg per kg per day, and the dosage can be increased up to a maximum of 80 mg for the first week and is tapered over the following weeks. The next is the Ramsay-Hunt syndrome. Steroid therapy should be employed with proper caution in case of Ramsay-Hunt syndrome, especially with periauricular lesions because of the fear of dissemination of the varicella zoster infection. So definitive treatment for Ramsay-Hunt syndrome is antiviral therapy, but the steroid therapy can be used as an adjunct therapy in case of Ramsay-Hunt syndrome. And in case of post-herpetic neuralgia, again prednisolone in a dosage of 40 mg is administered. And temporal arthritis, oral prednisolone is given at a dosage of 1 mg per kg per day or between 40 and 60 mg per day. And Mees's granulomatous cheilitis, the submucosal injections of 0.5 ml of betamethasone once a week followed by 2 injections every 4 months can be given to cure the cheilitis. In case of restorative dentistry, the intracanal medicaments are administered along with steroids. The steroid antibiotic combination is the mix is referred to as the leader mix. It contains 1 gram paste which contains triamcinolone acetonide and demiclocycline. Steroids can also be used as root canal sealers. For example, hydrocortisone 1% is used as a root canal sealer in some cases. And perioperative corticosteroid use in dentoalveolar surgery. After the third molar removal and dentoalveolar surgery to reduce the post-surgical edema, we can give dexamethasone at a dosage of 8 mg IM. Steroids can also be used in cases of temporomandibular joint disorders. Intra-articular corticosteroids have been proved useful in reducing the pain, swelling and dysfunction in inflammatory diseases of TMJ disorders. The recommended drugs for intra-articular injections include hydrocortisone, prednisolone, dexamethasone and betamethasone. Though the corticosteroids are used widely in dentistry, there are some limitations for this corticosteroid therapy. Although the benefits of corticosteroid therapy are derived from the short-term vascular changes and limited immunosuppression, prolonged or high-dose glucocorticoid therapy has multiple side effects. This is a chart which shows the tapering of the dosage of corticosteroids. There are some specific contraindications for the use of corticosteroids, both topical and systemic. The topical steroids are contraindicated in case of primary bacterial infections and hypersensitivity, and the systemic steroids are contraindicated in the following conditions like peptic ulcer, diabetes mellitus, hypertension, pregnancy, tuberculosis and other infections, osteoporosis, herpes simplex virus infection, psychosis, epilepsy, congestive heart failure and renal failure. There are also some tissue specific side effects of high dose or prolonged corticosteroid therapy. In case of adrenal gland, it causes adrenal atrophy and Cushing syndrome. When coming to the cardiovascular system, it may result in hypertension, thrombosis and vasculitis. And the central nervous system, it may result in changes in behavior, cognition, memory and mood. And GI tract, gastrointestinal bleeding, pancreatitis and peptic ulcer. Immune system, corticosteroid causes broad immunosuppression and activation of the latent viruses. In case of integument, it causes atrophy, delayed wound healing, erythema, hypertrichosis, perioral dermatitis, petechiae, glucocorticoids induced acne, striate distensis, hypopigmentation and contact dermatitis. In case of musculoskeletal system, it may cause bone necrosis, muscle atrophy, osteoporosis, retardation of bone growth, and in eye, it may cause cataract and glaucoma. Kidney, it causes increased sodium retention and potassium excretion, and reproductive system, it may result in delayed puberty, fetal growth retardation and hypogonadism. There are also some adverse effects of treatment with topical corticosteroids. So when the topical corticosteroids are applied locally, they may result in appearance of oral candidiasis in 25 to 55% of the patients, and it can be treated with nystatin cream formula. The other side effects include burning mouth, hypoglycemia, oral hairy leukoplakia and hypersensitive reactions to the drug. The systemic side effect of using topical corticosteroids include the reversible suppression of the HPA axis in case of high potency topical steroids. There are some specifications which should be used for steroid cover for dental patients on long-term steroid medication. So in case of minor surgical procedures under local anesthesia, there is only very low risk for developing adrenal crisis. So in such cases, the guidelines are the patient should simply maintain their usual dosage of corticosteroids. However, those patients taking high dose of corticosteroids should double the dosage of the steroid on the day of the surgical procedure. And in case of surgical procedures under general anesthesia, there is need for perioperative glucocorticoid supplementation for patients on exogenous steroids, that is on long-term steroid therapy, that should be determined by the severity of the surgery and the pre-existing glucocorticoid dose. So patients undergoing general anesthesia for minor surgery, 100 mg hydrocortisone intramuscularly should be administered and the usual glucocorticoid medications are maintained. For major surgery, 100 mg hydrocortisone is delivered as a bolus preoperatively, followed by 50 mg of hydrocortisone 8-hourly for 48 hours is adequate. To conclude, corticosteroids are used for the treatment of various diseases affecting the oral and maxillofacial region and have widest application in chronic and acute conditions of allergy, inflammation and many other conditions. Corticosteroids have proven to be the archetypal and double-edged sword of medicine. Their judicious use is of paramount importance and thorough knowledge is very important as the risk associated with the steroids are equivalent to their therapeutic benefits. Thank you everyone.